Yeah, yeah. Hi, everyone. I'm Dr. Java. I'm a kidney doctor at Washington University School of Medicine in St. Louis, Missouri. And in my practice, I see patients with chronic kidney disease and those after a kidney transplant.
Hi, everyone. I'm Dr. Java. I'm a kidney doctor at Washington University School of Medicine in St. Louis, Missouri. And in my practice, I see patients with
To advance the slide. I'm going to be talking to you about complement-mediated TMA today, since these are my disclosures. Since this is the first time the TMA Consortium is doing this talk, and I know the topic was updates in treatment, but what I would really like to do with you all today is give you an overview of the disease, discuss the different causes of thrombotic microangiopathy and how you come to a diagnosis, discuss genetic testing about who to test, what to test for, and then discuss an approach to treatment with a focus on what's new in the pipeline. So thrombotic microangiopathy is a term that describes a pathological process which is caused by thrombotic occlusion of the microvasculature. And what that means is that there is a blood clot in the small vessels that leads to what is called organ damage or ischemia or infarction. As you can see in the picture here on the left, which is labeled as a healthy vessel or a healthy blood vessel, the blood is flowing smoothly. On the right is a blood vessel that has been damaged by thrombotic microangiopathy. You can see the blood clot that leads to the turbulent blood flow. So typically, this kind of disease presents with a certain set of features. We call it microangiopathic hemolytic anemia. And what that means is that because of the clot formation in the blood vessel, there is breakdown of the red cells. And that can show up in the blood work as decrease in hemoglobin or anemia. Patients might have schistocytes when they do a peripheral smear. There is a specific blood test called lactate dehydrogenase or LDH, which is elevated. Because of the blood clot, there is also platelet that are consumed, and that leads to low platelet count or thrombocytopenia. And because the blood flow is obstructed due to a blood clot, it leads to organ injury because of infarction or because of decreased blood flow. Although kidneys are the most important organ involved, thrombotic microangiopathy actually is a systemic disease and can lead to strokes, seizures, even myocardial infarction, which is heart attack. Patients might have gangrenes in their tips of fingers and toes. Now, thrombotic microangiopathy is a broad term, and there are multiple causes for the disease. So some of you may have heard about ADAMTS13 deficiency-associated TMA, which is commonly known as TTP, complement-mediated TMA, which is what I'm going to talk about today, pregnancy-associated TMA, which can happen with preeclampsia or HELP, and there'll be sessions on that later on. However, it's important to remember that thrombotic microangiopathy can also be caused by a number of medications or drugs, and I've listed some of those here. Certain autoimmune diseases, commonly lupus, can be associated with TMA. Certain cancers and drugs for cancers or chemotherapy can cause TMAs. There are multiple infections that are associated with it, and we've seen some thrombotic microangiopathies with COVID. There are multiple other metabolic disorders that can be associated that are listed here. And patients after a kidney transplant or a stem cell transplant also can develop a TMA due to multiple risk factors. But for the purposes of my talk today, I'm going to focus on complement-mediated TMA, or what we call as atypical hemolytic uremic syndrome. So before I move forward, I want to give you a brief overview of what complement is. So your immune system, we're going to go back one slide. So your immune system, complement is part of your immune system, and your immune system is your defense against infections, against viruses and bacteria. Now, your immune system is made up of two main components. One is called your innate immune system, which is what you're born with. There is no prior sensitization required. And a key component of that innate immune system is called the complement system. The second part of your immune system is called the adaptive or acquired immune system, which you develop as you grow and you go through life. And that system, a major component of that is antibodies, which you develop as you get exposed to infections or through vaccinations. So antibodies are your acquired specific component, but the complement is your non-specific innate component. And the term complement comes from the fact that it was initially thought to complement the function of the antibodies of your immune system. Next slide. So there are three ways your complement system is activated, and I'm going to go over that very briefly here. You may or may not have heard that there are three pathways that the complement system gets activated. There is a classical pathway, there is a lectin pathway, and there is an alternative pathway. So the classical pathway gets activated whenever you get exposed to a bacteria and you develop an antibody, and that antibody binds to the bacteria. The lectin pathway is very similar to the classical pathway in that lectins are certain kinds of proteins in your system, and they recognize different patterns on the surface of a bacteria. However, the alternative pathway is different from these two, and it is continuously on in all of our bodies. It's constantly ticking over, as we call it, and it's surveying your intravascular, your blood space for any infections. But in the presence of a trigger, in presence of an infection or any other triggers, this alternative pathway can get revved up pretty quickly. The goal of the complement activation is really to form a certain molecule, which is called C3b. And what that C3b does, it actually tags the bacteria or whatever the trigger is or the debris that comes in, and it takes that debris and bacteria and gets it ready to be handled and to be removed from your bloodstream. If the activation keeps going on, then a certain complex called the membrane attack complex is formed, and that complex pokes holes on the surface of a bacteria and gets rid of the bacteria. So really the purpose of your complement system is to give you a defense against your infections, to prevent debris or immune complexes, and to really keep your body in homeostasis. Next slide, please. But for the purposes of our disease, what I want you to focus on is the alternative pathway. As I mentioned, the alternative pathway is in a state of constant on. It's constantly converting C3, a molecule, to C3b at low levels. And in the presence of a trigger, this pathway can get hyped up, can get revved up, and get really, really hyperactive. And therefore, nature has provided our body with certain regulators to keep this particular pathway in check. And these are called regulators of complement activation. And these include certain proteins called factor H, factor I, complement receptor 1, as you can see here, membrane cofactor protein. So what happens in atypical aHUS then is, let's go to the next slide, is that in some way there is a problem with the regulation of this pathway. So certain patients may have mutations in these regulators that make these regulators ineffective in controlling this pathway. So there may be a mutation in factor H, there may be a mutation in factor I. So these regulators cannot function and they cannot control the alternative pathway appropriately, and that leads to the pathway getting revved up. Another set of mutations may be in, please go back. Another set of mutations may be in proteins like C3 or factor B, such that these proteins become resistant to being regulated by some of these regulators. Some of our patients also have what we call as acquired factors because they develop autoantibodies. Factor H autoantibody is a common one in atypical HUS. And one of the ways we speculate that factor H autoantibody works, it inhibits or it interferes with the work of factor H's regulation. So it interferes with the regulation of of factor H, which is a regulator. Next slide, please. So as you can see on the slide here, for complement and disease to happen, we need a real balance between activation and control. If there is too much activation and insufficient regulation, like I just discussed, it can lead to a disease like atypical HUS. On the other hand, if you control the complement pathways too much and there is insufficient activation, it can lead to a predisposition to infections. And it's a balance that is really needed to prevent infection and to prevent inflammation. Next slide, please. So that brings us to what causes thrombotic complement-mediated TMA or atypical HUS. So it really, as I've explained, is due to a dysregulation or an overactivation of that specific pathway of the complement system, the alternative pathway. And as I just showed also, the etiology or the cause of this overactivation most commonly is either a genetic mutation in one of the complement proteins, which we find in about 50 to 60% of patients, or an acquired defect in the form of an autoantibody. Now, oftentimes you may have heard that the disease is not fully penetrant. That term really means that in addition to the genetic factors, a lot of patients need an environmental trigger to manifest disease. So you may have carried a mutation all your life, but you may not manifest disease until maybe you're young adult or older age. That is because you needed some kind of a trigger, and that trigger could be many things. It could be an infection, it could be pregnancy, it could be a surgery, it could be a certain drug. And sometimes there is a challenge in differentiating whether it's an underlying genetic cause which is causing the disease, or is it that trigger which is causing the disease? And we'll go over how to tease some of that out in my next few slides. Next slide, please. An important thing to remember is that the risk of recurrence of this particular disease after a kidney transplantation is high, and it often depends on the underlying complement abnormality. However, as we have understood the pathophysiology of this disease over the years, and with the availability of the drug, the C5 inhibitor or the eculizumab and the ravulizumab, it has allowed for successful kidney transplantation in these patients, which was not a possibility until 10 years ago. Next slide, please. So coming to then genetic testing, since genetics holds such an important aspect of the disease, so many of you probably have undergone genetic testing and are seeing a physician and you know what your mutation is. Others may not have done it. But to go over what happens when we are concerned that a patient has atypical HUS, we do consider genetic testing in those patients. And there are multiple labs in the country that do it. Most centers will test for 13 common genes, and I've listed those genes here. And when these genes, when the testing is done, if there is a mutation, it is reported as one of 5 levels that is also listed here. So you may have a mutation that is pathogenic or likely pathogenic. You may have a mutation that shows up as benign or likely benign, or it may show up as a variant of uncertain significance. 2 other important things to remember about this disease is we call it autosomal dominant, which means that you really need one defective allele, like you need one of the genes. So you have 2 parts of your DNA. You only need one defective part to manifest this disease. And some patients may have mutation in more than one gene, and we call it digenic inheritance. So you may have a mutation in C3 and factor I, so you may have more than one. Next slide, please. So if you have a report that says that you have a pathogenic or a likely pathogenic mutation, that already clears the diagnosis, which means that mutation is the problem. It is the mutation that is causing the disease in your case. However, the challenge comes when you have certain clinical features or manifestations of the disease, but your genetic report shows that it's a variant of uncertain significance. And that is where it's a conundrum for many patients. It's unclear what that mutation means. And there are multiple ways that can be teased out. There are certain labs that can test that mutation to identify if it is functionally deleterious or not. And there you could do certain other testings to really get to the bottom of whether that mutation is problematic or not. However, it's important to remember that it's not okay to think of a variant of uncertain significance as something that is not important or something that is benign and not causing disease. It means that it needs further investigation. Next slide, please. So in this table here, I've given you just an overview of the common complement proteins that we find mutations in. On the third column is listed how frequently they're found in patients with atypical hemolytic uremic syndrome, and what is the risk of end-stage kidney disease if you have a mutation that is problematic in one of those proteins and it is not identified or treated on time. And on the last column here shows the risk of recurrence after a kidney transplantation if you carry one of these mutations and if you're not treated. And as you can see here, factor H is the most problematic protein to have a mutation, is because it is also the most potent regulator of the complement system. Next slide, please. So that kind of sums up on why genetic testing is important in our patients. As I mentioned here, it's important in diagnosis, at least long-term understanding what the cause of disease is, and it provides prognostic information regarding what is the risk of progression of the disease to end-stage kidney disease, what is the risk of relapse if we stop treatment, what is the risk of recurrence after a kidney transplant? And very importantly, if the patient does lose a kidney to atypical hemolytic uremic syndrome and is looking for a kidney transplant and then has a living donor who comes in and wants to donate a kidney, knowing the genetics is critical, because if the donor carries a genetic mutation that the patient carries, then we do not want a kidney from that donor because it is going to precipitate disease in the donor. And those kind of decisions are extremely critical and helped by genetic testing. Next slide, please. So that brings me to who should undergo genetic testing. Of course, the obvious answer is that if you have a history of thrombotic microangiopathy, if there is a concern for atypical hemolytic uremic syndrome based on your clinical features, if there is a family history of thrombotic microangiopathy or atypical hemolytic uremic syndrome. The two other important things that are often missed is that if there is a history of severe hypertension in younger patients, I often see patients who come to me for a transplant evaluation. And in those younger patients, they present with a story like, I was doing fine one day and then I got up and I had a headache or I had a blurry vision and I went to the emergency room and my blood pressure was 200/100 and I was told I was in kidney failure. Oftentimes, those patients are labeled as having kidney disease from hypertension. But that is a misdiagnosis because these patients, especially if they're younger and they present with severe hypertension, they should undergo genetic testing. In our practice, we've identified many such patients who were found to have genetic mutations and their actual diagnosis was a thrombotic microangiopathy or atypical aHUS and not hypertension. Another cause that is important to remember is young women who've had preeclampsia and they lose their kidney from preeclampsia. So the preeclampsia never recovers and they go into kidney failure. Those patients are important and they should undergo genetic testing to figure out why the preeclampsia was so aggressive. Next slide, please. So these are a list of investigations that you could consider in a patient with atypical aHUS. As I said, genetic testing in the patients that I mentioned. In addition, there are several other serum testing, what we call antigenic levels, looking for proteins, looking for autoantibodies, should be done in our patients. Next slide, please. So this is a flowchart that I designed to really put things together. So it's, first of all, it's critical that thrombotic microangiopathy is diagnosed. And in the red box on the right, I mentioned some of the features we've discussed. So there is a patient who has anemia, low hemoglobin, thrombocytopenia, low platelet count, elevated lactate dehydrogenase, as I mentioned. Haptoglobin is another test that identifies breakdown of the bloods. Schistocytes on the peripheral smear. There is a biopsy that shows a thrombotic microangiopathy. So if there is a patient who has these, and you don't have to have all of these, if there's a combination of these in some form and there is a concern for thrombotic microangiopathy, there's a stepwise process you want to go through. Obviously, you want to rule out what we know as TTP. Are there any infections? Are there any underlying autoimmune conditions like lupus that the patient may have? Is the patient on any drugs? If it's a kidney transplant patient, is there any rejection? Once you've gone through that checklist and you think that the thrombotic microangiopathy is persistent, at that point, complement studies are important. Genetic testing is important, as I mentioned. If you have a variant of uncertain significance, that needs to be further investigated. And on the left in the green column, I mentioned some of the testings that your physician would order. And based on a combination of this genetic testing and your antigenic testing, you define what is going on with the patient and come to a diagnosis of whether this is complement-mediated thrombotic microangiopathy or aHUS. Next slide, please. So coming to treatment for atypical aHUS, currently, as you know, eculizumab and ravulizumab are the only anti-complement agents available. And at this point, they're great drugs, they work well. What we don't clearly understand in some of our patients is how long our patients need to be treated. And I'm going to show you a slide here on how I make decisions in my practice, and a lot of that is based on genetics. However, it's possible that some of these drugs can be discontinued in certain patients. There are multiple studies, as Dr. Mazeppa mentioned earlier in the introduction, that we need to figure out what the long-term outcomes of our patients are. Are they dependent on certain genetics? What are the different triggers that are there any biomarkers that we can understand in our patients? And ultimately, the goal is to be able to identify therapy that is going to work specifically for each patient. And there are multiple other agents in the pipeline that we will have more data on over the next few years. Next slide, please. So based on what we do in our practice, this is a flow chart on how we decide in terms of how long we keep our patients. So a patient who has a pathogenic mutation in any complement protein, a patient who had a thrombotic microangiopathy and lost a kidney to that thrombotic microangiopathy and may have a recurrence in the kidney transplant, those patients are kept on drug forever. Even if you don't have a genetic mutation identified, but you have a biopsy that shows thrombotic microangiopathy very clearly in the native kidney, we tend to keep those patients long-term on the drug. And if you have an acquired factor like factor-H autoantibody that we are not able to remove with any kind of treatment, those patients stay on the drug. There are a small group of patients that we stop treatment on. So patients who have acquired factors that are factor-H autoantibodies and they're successfully treated. There are multiple ways you could treat those, plasmapheresis, and there are rituximab. There are certain treatments that we may use to remove. And if you don't have those autoantibodies, then treatment can be stopped with very careful monitoring. And MCP mutation is one that if you have a mutation and if you get a kidney transplant, those patients can stop treatment, but not prior to getting a kidney transplant. And then, like I said, variant of uncertain significance really needs to be investigated. It's critical that those VUSs are not thrown away as benign, or they're of uncertain significance. They may be pathogenic, they may be benign, but without investigation, you do not know. Next slide, please. So coming to what's in the pipeline for atypical hemolytic uremic syndrome, as you know, eculizumab has been on the market for several years. We now have the longer-acting version, which is the ravulizumab. There is a drug which is specifically used, which is the crovalimab. For patients, you may have heard some patients may have a mutation in a particular protein C5 where the eculizumab works. And if there's a mutation in some patients, that may not work. And so there is a drug that actually can bypass that, although that mutation has been found more in the Asian patients. There are other drugs. There is avacopan, which is a C5a receptor 1. It was trialed in a few patients, and we have not heard a lot more since then. There is more to come on the MASP2 inhibitors, and there are several other drugs which are called biosimilars, which means that they're similar to eculizumab, which we will be expecting to hear more about those in 2025 and after. Next slide, please. One thing I want to talk about, take a couple minutes, is talking about the donor kidney. As I mentioned earlier, if you have atypical hemolytic uremic syndrome and you lose a kidney to that and you're looking for a transplant, it is extremely important to have this in mind. So if you have a donor who wants to donate, a living-related kidney transplant is relatively contraindicated in patients who have an atypical hemolytic uremic syndrome. And this is primarily to protect the donors. Because, like I said, if you have a mutation and your donor carries a similar mutation, you do not want a kidney. Now, sometimes in our patients, we don't identify the mutation. However, even in those cases, taking a kidney from a donor can be problematic because not identifying a genetic mutation does not mean that you don't have a genetic cause. It's just that you may have a cause that we haven't looked for, and therefore it's risky to take kidneys from donors, even in patients who don't have a genetic etiology. So it's a very individual and case-by-case decision we make. The only time we will accept a donor is that if a patient has a pathogenic mutation in a complement protein, and we determine that that mutation is the cause of atypical hemolytic uremic syndrome in that patient, and the donor's been extensively tested and does not carry that particular mutation, we may consider, again, that's a decision between us, the recipient, and donor. It's a combined decision, understanding all the risks and benefit of that option. Next slide, please. And so in conclusion, I want to say that, first of all, it's absolutely critical to identify patients with thrombotic microangiopathy. Like I said, there are multiple causes of TMA, and coming down to that, this is clearly complement-mediated TMA is critical. Having a low threshold, identifying those the clinical features is important. Then the genetics, knowledge of complement genetics, it has definitely transformed our understanding in, the pathogenesis of this disease. And I really encourage wider utilization of genetic testing, particularly in patients where I mentioned those with younger patients with high blood pressure, patients with preeclampsia, or for that matter, any TMA that has been more aggressive should undergo genetic testing. And I think a combination of all our genetic testing and the antigenic testing will ultimately help us define what is the cause of disease in our patient, how do we treat them, what are the long-term outcomes. And ultimately, the goal is to really tailor treatment to our patients, which we call precision medicine or individualized medicine, and to really bring the right treatment for the right patient at the right time and for the right duration. And with that, I will stop here and we'll take questions.